Let's talk about a muscle most people don't know they have. One that sits so deep in the body that you can't see it, can't easily touch it, and under normal circumstances can't even consciously feel it. But this muscle, when it's not functioning correctly, is connected to three problems that together affect a huge proportion of adults over 50. Urinary leaking, chronic lower back pain, and a belly that won't flatten no matter what you do. I'm talking about the psoas major, the deepest, most anatomically complex, and most clinically underappreciated muscle in the human body. And the reason these three seemingly unrelated problems, leaking, back pain, bloated belly, so often appear together in the same person is not coincidence. It's anatomy. It's fascial connectivity. It's the way the body compensates when a core structural muscle stops doing its job. When you understand the mechanism, the convergence makes complete sense. And more importantly, when you understand the mechanism, you understand what to actually do about it. The psoas major originates along the sides of the lumbar vertebrae, the 5 bones of your lower spine, attaching specifically to the vertebral bodies and the intervertebral discs at every level from T12 down to L5. It then travels through the pelvis, crossing the pelvic brim, passing beneath the inguinal ligament, and inserting on the lesser trochanter of the femur, the inner bump at the top of the thigh bone. This anatomical journey is not incidental. It means the psoas is the only muscle in the human body that directly connects the lumbar spine to the lower extremity. Every step you take, every time you lift your leg, every time you bend at the hip or stabilize your trunk while moving, the psoas is involved. But its role extends far beyond simple hip flexion. Because of its direct attachments to the lumbar vertebral bodies, it acts as a powerful spinal stabilizer, compressing the lumbar discs and maintaining lumbar lordosis when it contracts in a coordinated way with the lumbar multifidus and deep abdominal muscles. It is part of what researchers call the local stabilizing system of the spine, the deep, tonic, postural muscle group that provides joint-by-joint spinal stability throughout every movement and every moment of sustained posture. When the psoas is dysfunctional, when it's either chronically shortened from prolonged sitting or inhibited and weak from disuse, the spinal stability it provides is compromised, and the body recruits other structures to compensate. That compensation is where the back pain comes from. And it's where the abdominal appearance and the pelvic floor dysfunction come from too. If you're finding this useful and you want this level of clinical depth on a regular basis, subscribe. We're building a 100,000 person community of people who want real anatomical information presented clearly, not oversimplified, not alarming, just accurate and actionable. This is what we do here. I want to tell you about a patient I'll call Carol. She was 56 years old. She came in with 3 complaints: chronic low back pain that had been investigated extensively and attributed to mild degenerative disc disease at L4 to L5, urinary urgency and occasional leaking that had been addressed with pelvic floor exercises she'd been told to do but hadn't fully understood, and a protruding lower abdomen that made her feel, as she put it, permanently pregnant despite maintaining a reasonable body weight. She'd seen 3 different specialists for these problems. Each had evaluated their piece. Nobody had connected the dots. When I did a comprehensive assessment, including functional movement analysis, a proper history of her daily posture and activity patterns, and a thorough evaluation of her core muscle function, what emerged was a clear, coherent picture. Carol sat for 9 hours a day in a slightly reclined position with her hips flexed at approximately 70 degrees. Her psoas was chronically shortened on the right side, pulling her lumbar spine into excessive lordosis and creating an anterior pelvic tilt. Her diaphragm was compressed into a suboptimal position because of that anterior pelvic tilt, reducing its capacity to descend fully on inhalation. Her pelvic floor, which works in coordinated synergy with the diaphragm, the psoas, and the deep abdominals, had lost that coordination. The pressure management system of the abdomen and pelvis had broken down, and her transverse abdominis, the deep corset muscle of the abdomen, was inhibited and essentially not firing during movement, leaving her abdominal wall without its primary tensioning mechanism and producing the anterior abdominal protrusion she described. 3 complaints, 1 cascade, and the cascade had a beginning, the psoas. Here's how to understand the core mechanism using an analogy that actually captures the biology. Think of the trunk of your body as a pressure cylinder, a sealed container with a top, a bottom, and walls. The top of the cylinder is your diaphragm. The bottom is your pelvic floor. The walls are your transverse abdominis at the front, your lumbar multifidus at the back, and the psoas and iliacus forming part of the posterior lateral architecture. When this cylinder is intact and properly tensioned, it manages intra-abdominal pressure beautifully. When you cough, laugh, sneeze, or lift a heavy object, the pressure inside the cylinder rises. In a healthy system, the diaphragm, pelvic floor, transverse abdominis, and multifidus respond simultaneously and reflexively, redistributing that pressure surge without it escaping downward through the pelvic floor or forward through the abdominal wall. This is what continence looks like at a mechanical level. Now imagine that the psoas, which spans the length of the cylinder and directly influences the position and tension of the lumbar spine, the diaphragm, and the pelvic floor, is chronically shortened and pulling the lumbar spine into excessive lordosis. The cylinder tilts. The diaphragm is no longer in its optimal position to descend. The pelvic floor is no longer in its optimal position to resist downward pressure surges. The transverse abdominis is inhibited by the neurological pattern that the postural dysfunction has established, and the pressure management system fails. Pressure escapes downward, producing stress urinary incontinence with coughing or sneezing or jumping. Pressure escapes forward, producing the abdominal protrusion. And the lumbar spine, now without its coordinated deep muscular support, is vulnerable to the compressive and shear loads of daily movement. That's the back pain. 1 cylinder. Dysfunctional because of 1 structural muscle. 3 consequences. Sign 1. The lower abdominal protrusion that doesn't match your weight. The clearest sign that the psoas and deep core system are compromised is a lower abdominal protrusion that is disproportionate to your overall body composition. This is different from subcutaneous fat, which distributes across the entire abdominal wall, and different from visceral fat, which fills the abdominal cavity and creates a round, firm, global enlargement. Psoas-related abdominal protrusion is specifically in the lower abdomen, below the navel, and has a characteristic posture associated with it: an anterior pelvic tilt, an increased lumbar lordosis curve, and a forward displacement of the lower abdominal contents that occurs because the diaphragm and pelvic floor are no longer managing pressure effectively, and the transverse abdominis is not providing its corset tensioning function. If you stand sideways in front of a mirror and your lower abdomen protrudes forward while your lower back is excessively curved inward, the anterior pelvic tilt pattern is present. If crunches and planks have not helped, and they typically don't in this situation, and in some cases make it worse, it is because those exercises strengthen the superficial rectus abdominis without addressing the underlying coordination failure of the deep core system. You're tensioning the wrong layer. Sign 2. Lower back pain that's worst after sitting and worsens with standing. The lumbar spine pain pattern associated with psoas dysfunction has specific characteristics that distinguish it from other sources of back pain. It tends to be worst after prolonged sitting because the psoas has been in its shortened position, and when you stand up, it immediately pulls the lumbar vertebrae forward and compresses the posterior disc and facet joint surfaces. It often presents as a deep, dull ache in the lower lumbar region that spreads into the buttocks or the front of the hip. It typically worsens with sustained standing, because without the dynamic support of a properly activated psoas and deep core system, the lumbar spine is now hanging off its passive structures. And those structures, the discs, the ligaments, the facet joint capsules, become progressively loaded over time. And it often eases with walking, because walking activates the psoas rhythmically, partially restoring its dynamic function, and moves the lumbar spine through the extension-flexion cycle that relieves passive tissue loading. If this pattern of sitting to standing pain, worsening with sustained postures, and easing with walking describes your experience, the psoas is almost certainly a significant contributor. This is consistent with the clinical presentations described in research on lumbar motor control dysfunction published in the journal Spine over the past 3 decades, particularly the work of Stuart McGill at the University of Waterloo on spinal stability and psoas function. Drop your age in the comments now. Here's specifically why it matters for this topic. The psoas core pelvic floor cascade I've described affects people of all ages, but the clinical presentation shifts meaningfully across the lifespan. In adults under 45, the predominant issue is usually posture-driven psoas shortening from sedentary work patterns. The biology responds quickly to targeted exercise, and restoration of function within 8 to 12 weeks is typical with the right approach. In adults between 45 and 65, hormonal changes begin to layer onto the structural problem. In women, the decline of estrogen around menopause reduces the tensile strength and collagen content of connective tissue, including the pelvic floor fascia. This means that the same intra-abdominal pressure surges that a younger woman's pelvic floor could absorb now exceed the structural capacity of a more compliant, less tensioned pelvic floor. The leaking becomes more frequent. The margin for error is smaller. In men in this age range, prostate enlargement, present to some degree in the majority of men over 50, can contribute to urinary urgency and frequency, which compounds any pelvic floor dysfunction. Over 65, the inhibition of the deep core muscles often becomes more entrenched, requiring more time and more targeted work to reverse. But the biology absolutely responds to the right stimulus at any age. Your age tells me which components of the solution need the most emphasis. Sign 3. The urinary leaking pattern, stress incontinence, and the pressure surge. Stress urinary incontinence, leaking with physical stress events like coughing, sneezing, laughing, jumping, or heavy lifting, is the most common and most mechanistically clear manifestation of pelvic floor pressure management failure. Let's be precise about the mechanism, because the standard advice about Kegel exercises, while not wrong, is often incomplete in a way that limits its effectiveness. The pelvic floor does not work in isolation. It is one component of the intra-abdominal pressure management system. For the pelvic floor to respond effectively to a pressure surge, the kind produced by a sneeze, it needs to contract reflexively, in coordination with the diaphragm and the transverse abdominis, before the pressure peak arrives. This is called anticipatory postural activation, and it is a learned neuromuscular pattern, not a simple strength issue. Research from the University of Queensland, the same group that pioneered our understanding of deep cervical flexor dysfunction and neck pain, has shown that in women with stress incontinence, the timing and coordination of pelvic floor activation relative to pressure events is impaired, even when the absolute strength of the pelvic floor muscles is normal. This means that simply doing Kegel contractions without addressing the coordination deficit and the broader core integration often fails to resolve the problem. The pelvic floor needs to be trained as part of the system, timed, coordinated, and connected to breathing mechanics, not as an isolated squeeze exercise. Sign 4. Hip flexor tightness and limited hip extension. The psoas is the primary hip flexor. When it's chronically shortened, it limits hip extension, the ability to move your thigh behind your body, as happens in the back step of walking or when you stride uphill. A simple test. Lie flat on your back, draw one knee to your chest, and observe what happens to the other leg. If the opposite thigh rises off the floor, even slightly, when you pull the near knee to your chest, the psoas on that side is shortened. This is Thomas's test, used in orthopedic assessment for decades. A positive Thomas's test in the context of lower back pain, abdominal protrusion, and pelvic floor dysfunction is the clinical fingerprint of the pattern I've been describing throughout this video. The shortened psoas is not just tight. It is actively pulling the lumbar spine forward, compressing the lumbar facet joints on the posterior side, and placing the diaphragm and pelvic floor in mechanically compromised positions. If you have a positive Thomas's test, the exercises I'm about to give you are specifically designed to address exactly that pattern. Here is the deep core restoration protocol, the specific, evidence-grounded daily practice that addresses the psoas, the diaphragm, the pelvic floor, and the transverse abdominis as an integrated system. This takes approximately 10 to 15 minutes per day and requires no equipment. Step 1. The 90-90 hip flexor release, 5 minutes. Lie on your back with your hips and knees both bent at 90 degrees, calves resting on a chair or couch at exactly hip height. This position places the psoas at its resting length, removing its pull on the lumbar spine. Breathe slowly and deeply. Inhale through the nose for 4 counts, letting the belly and lower rib cage expand fully. Exhale slowly through pursed lips for 6 to 8 counts, allowing the abdominal wall to gently fall. The breathing in this position does 2 things simultaneously. It restores the diaphragm's position and its full excursion range, and it uses the respiratory cycle to gently lengthen the psoas through the pressure changes associated with inhalation. 5 minutes in this position daily. Research on respiratory muscle function and lumbar spine position, including work published in the Journal of Orthopedic and Sports Physical Therapy, demonstrates that the 90-90 position combined with diaphragmatic breathing significantly reduces lumbar lordosis and associated posterior lumbar disc pressure. Step 2. The transverse abdominis activation, the gentle drawing in from the 90-90 position. Exhale fully. At the end of the exhale, before your next inhale, gently draw your lower abdomen inward and upward, as if you're trying to make your hip bones move toward each other. Not a massive bracing or sucking in, a subtle, gentle tensioning of the deepest abdominal layer. Hold that gentle activation for 10 seconds while continuing to breathe normally on top of it. 10 repetitions. This is transverse abdominis activation, and it is the foundational step in rebuilding deep core function. Research by Paul Hodges at the University of Queensland, one of the world's leading authorities on motor control and lumbar stability, demonstrated that in people with chronic low back pain, the transverse abdominis consistently shows delayed activation timing and reduced tonic activity compared to pain-free controls. This exercise reestablishes that activation pattern at the neural level. It takes weeks of daily practice to rebuild. There are no shortcuts, but it works. Step 3. The coordinated pelvic floor breath, closing the system. Still in the 90-90 position, with your transverse abdominis lightly activated, inhale, allowing the pelvic floor to gently descend and open. This is important. Kegel culture has taught people to simply squeeze the pelvic floor, but healthy pelvic floor function involves both contraction and relaxation. On the inhale, the pelvic floor should gently drop, coordinating with the downward descent of the diaphragm. On the exhale, as the diaphragm ascends, gently lift the pelvic floor, not a maximum squeeze, a gentle elevation. This breath-coordinated pelvic floor activation is the foundational pattern for continence. 10 breath cycles daily in this position. Over 3 to 6 weeks of daily practice, the anticipatory timing of pelvic floor activation before pressure events begins to restore. Clinical practice experience and research from pelvic health physiotherapy, including work published in the journal Neurourology and Urodynamics, consistently shows that this coordinated breathing approach produces superior outcomes in stress incontinence compared to Kegel exercises alone. Step 4. The standing hip flexor stretch, restoring psoas length. Stand in a lunge position, 1 foot forward, 1 back. Lower your back knee to the floor. Keep your trunk tall and gently tuck your pelvis under, posteriorly tilting the pelvis slightly. until you feel a deep stretch in the front of the hip on the back leg side. Hold for 30 to 45 seconds, 3 repetitions per side. This is the kneeling hip flexor stretch, and it directly lengthens the psoas from its distal attachment. Research published in the International Journal of Sports Physical Therapy confirms that sustained stretching of the hip flexor group in this position reliably reduces anterior pelvic tilt angle over 6 weeks of consistent practice. This is the correction to the tilt that's compromising everything upstream. The reality is that the healthcare system divides problems into specialties: back pain to orthopedics or physiotherapy, incontinence to urology or women's health, abdominal appearance to fitness professionals. And so the person who has all 3 problems sees 3 different providers who each address one piece without ever seeing the full picture. That's not failure of character, that's specialization. But it means that the person who understands their own anatomy, who can see that 3 problems share one root, is in a position to address all 3 simultaneously with the same targeted practice. You now understand the anatomy. The psoas connects the spine to the leg and influences the diaphragm, the pelvic floor, the transverse abdominis, and the lumbar disc environment simultaneously. Restore the psoas. Restore the coordination of the pressure system. The back pain eases. The leaking reduces. The belly retracts. The system was always designed to work together. Give it what it needs to do so. Your health is your responsibility, not the pharmacy's. I'll see you in the next video. Let me add the nutritional and hormonal dimensions that sit underneath this structural cascade, because the conversation about the psoas and deep core is incomplete without them. Connective tissue, the fascia, ligaments, and tendinous structures that transmit force between the psoas, the pelvic floor, the diaphragm, and the lumbar spine, is a collagen-rich tissue. Collagen synthesis requires vitamin C, adequate protein, and the right hormonal environment. In postmenopausal women, the drop in estrogen directly reduces collagen turnover and lowers the tensile properties of fascial tissue throughout the body, including the endopelvic fascia that supports the bladder neck and urethra. This is why pelvic floor dysfunction and urinary incontinence increase so dramatically in the decade after menopause. It is not that the muscles weaken in isolation. The entire structural environment, the fascial scaffolding that the muscles operate within, becomes more compliant, less stiff, less capable of transmitting force efficiently. Targeted nutritional support for connective tissue health includes ensuring adequate protein intake, a minimum of 1 gram per kilogram of body weight per day, and up to 1.2 to 1.6 grams in older adults with established sarcopenia risk, alongside consistent vitamin C at 200 to 500 milligrams per day. The evidence for collagen peptide supplementation, specifically hydrolyzed collagen at 10 to 15 grams per day, has grown considerably in the past decade. A randomized controlled trial published in the British Journal of Sports Medicine found that collagen peptide supplementation, combined with a rehabilitation exercise program, improved tendon and connective tissue recovery compared to placebo. The mechanisms are plausible and the safety profile is excellent. For women post-menopause dealing with pelvic floor dysfunction, discussing hormone therapy with a qualified physician, specifically whether localized vaginal estrogen might address the tissue changes contributing to incontinence, is a reasonable and evidence-supported conversation. Localized vaginal estrogen carries minimal systemic absorption and has been shown in multiple trials to improve stress incontinence outcomes and pelvic floor tissue quality. Sleep matters here too, and in a way that's specific to the psoas. The psoas has a high density of receptors for cortisol, the primary stress hormone. Chronically elevated cortisol, which occurs with persistent poor sleep, chronic psychological stress, or dysregulated circadian rhythm, keeps the psoas in a state of chronic low-grade contraction. This is the neuroscience of why people carry stress in their hips. The psoas literally contracts in response to cortisol. A muscle that is chronically contracted cannot be adequately lengthened by stretching alone. The neurological tone has to be addressed simultaneously. This is why slow, deep breathing during the hip flexor stretch is not incidental. It activates the parasympathetic nervous system, reduces cortisol, and lowers the neurological resting tone of the psoas, making the mechanical lengthening of the stretch more effective. Improving sleep quality, reducing chronic psychological stress through evidence-based approaches, exercise itself, mindfulness-based stress reduction, social connection, is not a peripheral lifestyle consideration for people with psoas-driven back pain and pelvic floor dysfunction. It is part of the treatment. The muscle cannot fully release when the nervous system it's embedded in is persistently in a stress-activated state. And let me add one practical note on the role of breathing mechanics in daily life, not just during the exercise protocol. Most people, when they are seated for long periods, breathe in a shallow, chest-dominant pattern. The diaphragm barely moves. The lower abdominals and pelvic floor receive none of the gentle, rhythmic pressure fluctuation that diaphragmatic breathing provides. Over hours and hours of this pattern, the coordination between the diaphragm and the pelvic floor, the coordinated pressure management that prevents leaking and maintains deep core stability, degrades. Setting a reminder to take 3 to 5 deep diaphragmatic breaths every hour during the workday is a micro intervention that costs nothing, takes 30 seconds, and consistently maintains the neuromuscular coordination of the pressure management system between formal exercise sessions. Breathe in so that your belly moves first, then your lower rib cage expands, then your chest rises. Breathe out slowly and completely. 3 to 5 times, every hour. It sounds too simple to be worth mentioning. The biology says otherwise. Every deep breath is a micro-activation of the diaphragm, a micro-lengthening of the psoas through the fascial connections between them, and a micro-coordination rehearsal for the pelvic floor. Small signals, consistently delivered, produce lasting neuromuscular change. That is how the nervous system works. Give it the signal, every day, consistently, and watch the system it maintains.